knowing when and how to operate. I'm Dr. Rana Higgins. I have the pleasure of being joined by many leaders in hernia surgery today who are going to be talking with you on this webinar. A lot to learn. So thank you all for joining us. I just have a few introduction slides to talk a bit more about SAGES, and then I'll introduce our first speaker and kind of talk about the formatting for the webinar session today. So SAGES is the best organization and national society that we have. It's an amazing, amazing society. If you're not already a member, I strongly encourage you to become a member. This is a great depiction of the amazing leadership team of SAGES, wonderful mentors, colleagues, lots of major leaders in our field, and a wonderful opportunity for networking in a very inclusive society overall. There's a lot of benefits to SAGES membership. You get substantial registration discounts to SAGES meetings. You get cutting edge education and professional development. There's a variety of resident and fellow training courses that we hold, online learning, and then webinars such as today on various topics of interest. You have over 7,000 colleagues, experts in our field, and then obviously very active on SAGES social media. You'll get an online subscription to surgical endoscopy, as well as access to members-only research grants and career developments. And not to mention, and just kind of anecdotally, numerous involvement in leadership opportunities via committees, task forces, and peer reviews. So it's a very inclusive society where if you work hard and you put in the efforts, you'll see the results of that. So I encourage you all to get involved as you can. Now, SAGES has obviously the vision of reimagining surgical care for the healthier world, innovating, educating, and collaborating to improve patient care, and very strong values around inclusivity, innovation, service, excellent global community. And then for anyone who's been to a SAGES meeting knows that the unofficial value of SAGES is fun, and that is very true of all the colleagues that you'll meet at SAGES. So a wonderful society to be part of. What does membership look like? So active membership includes all surgeons in Canada and the United States. Candidate membership is for residents or those enrolled in fellowships. And then we have a medical student membership as well. So to learn more, you can go to the membership portion of the SAGES website. Really a wonderful society to get involved in as early in training as possible to get access to all of these benefits. And for those of you who are able, the next SAGES meeting is March 12 to 15 in Long Beach, California, with the theme of Waterfront Playground. So we hope to see you all there. Well, thank you all again so much for joining us. I'm really excited to introduce all of our speakers today. The way that the session will work is we're going to divide the topics up into 3 groups. We have 2 talks in each group: preoperative, intraoperative, and postoperative. I'll have 2 speakers in each group, and then after the 2 speakers go ahead, then we'll have a question and answer session. Please use the chat function in the Zoom so you can, if you have any questions while they're speaking, they'll also present some knowledge checks to you throughout the way. Please use that function, and I'll be moderating and monitoring that throughout. So we are super excited to have all of you, and it's my pleasure to introduce our first speaker, who is Dr. Sal Docimo, who's going to be talking to us about preoperative optimization and prehabilitation. Dr. Docimo is an associate professor of surgery at the University of South Florida. Thank you so much for joining us, Dr. Docimo. If you want to
Thanks
share
everybody.
with your expertise.
All right, Rana, thank you so much for the invite too, and thanks for SAGES for putting this on. So let me just share my screen here with you guys. All right, I'm going to ask the question. Can everyone see this?
Looks great.
All right. So I'm going to be talking a little bit about preoperative optimization, kind of prehabilitation. It's really, what can we do before surgery to improve the patient's outcomes, really improve them intraoperative and also postoperatively. And these are my disclosures. Really nothing specific in regards to these anything here that's related to this talk. But for pretty much what we're going to look at are we're going to try to identify what are the modifiable risk factors for ventral hernia repair. What does the current data actually say? And I'm going to just tell you what I do. And the reason why is because the data is not the greatest, right? It's not the best data. It's not conclusive. There's a lot of moving factors going on at the moment in regards to obesity, smoking, and even because of robotics as well. It's kind of shifting the goalposts a little bit. So I'm going to tell you in terms of what I'm currently doing for the most part. So ventral hernias, it's a big problem, right? Despite all of our minimally invasive techniques, there's still a lot of hernias out there. We do somewhere between, about 200,000 hernias annually, probably even more than that. You're talking about 350,000 incisionals probably. And they are associated with complications. If you look at the 30-day readmission rates, it's about 5%. So 5%, 350, pretty high. Surgical site infections of about 13%. And then recurrence rates even as high as up to 63%. So, we do a decent job. We don't do a fantastic job. And I don't think it's because, we're doing a bad job. It's simply because this stuff is hard. Complex hernia repair is hard stuff. The abdominal walls of every single individual is different. All their comorbidities and factors that they come with, they're all different. And then you throw on top of that a pathology that is moving all over the place, right? The causes are very different, locations are very different. It just generates a really complex problem. So essentially, whatever we can do to limit poor outcomes, we should try to do as best as possible. So I'm going to briefly just kind of go over some, a few modifiable risk factors, and then I'll obviously hand it off to some of my colleagues here to kind of chat about some other options. But I'm going to give you a few of them that I think are probably important to just chat about this evening. So we're going to talk about smoking. So smoking is simply a problem because there's so many different byproducts of smoking that essentially just totally inhibit wound healing. And we could do an entire hour on the pathophysiology of this, but for the most part, you generate nicotine, carbon monoxide. I love to tell patients you generate cyanide when you smoke. That really kind of gets their eyes open. Nitrogen oxides, hydrocarbons. All these things have deleterious effects on wound healing. So, and the reason why is because it simply decreases oxygenation to tissue, causes ischemia. Now, if you have poor inherent wound healing, right, that's going to eventually lead to necrosis. So, if you're doing an open ab wall reconstruction on someone who's obese, where you have a really thick abdominal wall, who is smoking, they're going to be at a high risk of having an infection. And then you got to remember, infection is basically synonymous with a hernia recurrence down the line. So you can see where this kind of becomes important. Now, what a lot of people do is they'll also, they'll kind of put them on nicotine replacements for the most part to try to help them come off the smoking. People always kind of argue about that. They're like, hey, well, I don't know if they're smoking or not, can't trust them. The reality is most of the data says that if you put them on a nicotine replacement, it really doesn't have any negative effects because the byproducts of smoking are what causes the issues, okay? So for maximum response to smoking cessation, you got to wait about 3 to 4 weeks if you're going to get them to stop smoking. And that's because when you look at the wound healing properties, you basically go back to normal for the most part in terms of the wound healing processes at about 3 to 4 weeks. So if you're going to get them to stop, tell them to stop about 1 month before surgery, and they got to wait about 1 month to start again. All right, so the current recommendations, and again, this is for abdominal wall reconstruction surgery. In all honesty, when we're talking about inguinal hernias, I don't even ask about smoking anymore. All the data is pretty conclusive, in my opinion, that you don't really have to be concerned about smoking and when you're talking about an inguinal hernia repair. But I would still get them to stop smoking for about 4 weeks for abdominal wall surgery. I'm okay with them using nicotine patches. However, I can't test them with nicotine to see if they're smoking. So I have to trust the patient. If you don't trust your patient and you think they're going to say, well, I'm on the patch, when in reality they're still smoking, you gotta refrain a little bit, okay? And then again, obviously you don't want them to have smoking the day after surgery, so you gotta tell them to stop smoking 1 month after as well. So I kind of throw this up there too, just to keep this in mind. Recent data, smoking is not an issue, right? So if you look at some of the studies that are out there about, one study recently came out, 106 smokers versus 304, and these are in ventral hernias. SSIs were about non-significant, SSO slightly significant. Smokers, though, will have a high risk of pneumonia, okay? So that's why I said the data is slowly moving there, but what I currently still do is for complex ab wall, no smoking month before, no smoking month after. Inguinals, don't even care. All right, obesity. We're going to spend a little bit of time on this. I think it's an important topic, and it's a moving target a little bit simply because of robotics. Obesity is on the rise. I have to throw this up there because I'm talking about obesity, but we're going to keep going. So if you look at obesity and complex abdominal wall hernia, okay, when you Google any types of studies that are out there, you can clearly see that this is an important topic, okay? It's constantly being studied. It's obviously a significant concern. You know, we really got to keep talking about this, okay? And why is this a problem? Because we know that obesity causes, you know, surgical site infections and increases the risk. And again, as I mentioned before, surgical site infection is almost synonymous with, you know, with the hernia recurrence, okay? And you have all types of stuff, but we're going to use the terminology of surgical site infection specifically. So, and why is this a problem? I think this pathophys is kind of interesting. I think all the studies out there are pretty telling, right? So Sugarman did a lot of work with this a few years back. And he looked at some studies were really really nice, simple studies, but really telling. So he took UC patients who had a BMI less than 30, and he took gastric bypass patients who had a BMI greater than 35. And he saw that the incisions, in terms of incisional hernia formation, was pretty drastic. He had 20% versus 4%. And he found that 39% of those patients actually developed an incisional hernia had also had a concomitant surgical site infection. So that's obviously important to know too. And that's where that pathophys of bariatrics or ab wall comes into play, because when you look at the BMI, likely there's just poor wound healing because you have such a thick pannus that you simply don't get good wound healing, okay? And then you look at the time in terms of the recurrence rates and the time to the recurrences. Patients who have higher BMIs are obviously going to have a shorter amount of time before incisional hernias recur versus those who have lower BMIs. So lower BMIs, even very similar midline incisions, lower risk of getting a hernia formation. So the data on this is pretty telling that the higher BMIs who undergo incisions, they're going to have a higher risk of developing a hernia. Okay, kind of clear there. Why is it important? Obviously, not only just for outcomes in terms of our patients, but this is such a huge healthcare cost, right? So every time you get a wound site infection, which is obviously, you know, associated with obesity, you're talking about added costs of somewhere between $44,000 and $63,000. So pretty significant. So obviously we want to get really good outcome for our patients, but that's also in terms of looking at value for our healthcare and also driving down costs. It's important to look at that. And a couple other things too. At the moment, when we look at incisional hernia as predictive models, BMI has only really been the only good variable that we have at this moment in time that has been associated with hernia formation. Though there's a lot of radiology work being done in that field, but nothing conclusive at the moment. So I kind of mentioned this a little bit here. So, you know, possible mechanism behind this is really looking at, you know, increased intra-abdominal pressure, delayed wound healing. All right, all this comes into play when we talk about surgical site infections. And again, Shearman also looked at this in terms of obesity. We know that obese patients carry a higher level of intraoperative abdominal pressure, okay? So that abdominal pressure obviously puts a significant strain on the abdominal wall, which obviously when you talk about recreating the lineal elbow in a complex hernia repair, when you have constant tension pulling against the midline, you're probably going to get a recurrence at some point. So tension is not your friend in complex ab wall reconstruction. In obesity, abdominal wall of an obese patient is inherently always under more tension than those that are less obese, okay? Chronic inflammatory state. We know that, you know, adipose tissue is not benign. It's not benign stuff, right? So when you have patients who are obese, they're always being exposed to a high level of inflammation. And, you know, one basic study here just looked at the CRP, which is a marker for inflammation. And as the BMI went up, CRP in the patients went up, okay? So you can imagine a wound that's constant. Obviously, inflammation at the initial stage of wound healing is important, but constant inflammation is not, right? It's actually deleterious to inflammation because you don't get actual good deposition of connective tissue. You're simply not going to get any healing. So we got to be careful with that, right? So obesity, obviously, chronically inflamed, not a good setting, okay? So, you know, so we kind of looked at this a little bit deeper here. And obviously we know that when you look at some of these studies here, you know, obese patients tend to have higher recurrence rates, higher, you know, higher rates of infection as well. But the question is, you know, how do we really how do we pre-op these patients? How do we give guidance in terms of what to do with some of these patients, right? So when you look at patients, again, who have higher rates of BMI, all the data is pretty darn clear that SSIs are associated with a higher risk obesity is associated with a higher risk of SSIs, which is also related to the higher risk of hernia recurrences, okay? So that's pretty darn clear. So but how do we give guidance? So we did a study here a couple years back, and we looked at open ab wall reconstruction, and we stratified these patients to different BMI levels. And what we found was patients who have higher levels of BMI obviously are going to be at higher risk of SSIs, which I just showed you. SSIs are associated with hernia recurrences. Now, when you hit the BMI of 35 or more, the risk of an SSI was actually statistically significant. Okay. And again, this is an open ab wall reconstruction, not robotic, open ab wall. So I still use this cutoff tentatively around 35 because the data here was pretty significant, as we say. All right. So patients who had a BMIs over 35, they had a higher risk of reoperation, higher risk of readmission as well, and higher risk of SSI. So across the board, there's issues with the BMI. It's pretty darn clear, I think, in my opinion. And again, so how do you take this data? You have to be mindful just that every patient is different. Every procedure is different. But when you got a study of over 4,000, almost 5,000 patients, where anybody that hit that mark of BMI of 35 was at a really high risk of infection, you really got to take that you got to take that home with you. So in non-emergent patients, the recommendations refer to bariatric surgery. So I do bariatric surgery as well. It's kind of my two areas I focus on. So if anybody comes see me with complex ab wall, BMI is well over 35, I'm going to get them to lose weight, whether that's going to be with medications. If they're on the lower end, if they're on the higher end, they're going to get surgery. If they opt for, let's say, medication and lifestyle modification, I see them every about 3 months for their progress. And then I usually would do their ab wall reconstruction about 6 to 12 months after their bari surgery. Now, a couple of things. If their hernia symptoms worsen, you got to talk with the patient and say, hey, listen, we got to, these are the risks. This is what we're going to try to do. And you may have to take them to the OR earlier. That's what I'm saying. Every situation is a little bit different. So you got to tailor your approach a little bit, but that's kind of what I do for my patients. All right, diabetes. The EHS conducted a really nice systematic review for this a while back, and they really just showed that, the odds ratio was about 1.7 to almost just under 6 for postoperative wound infection when the hemoglobin A1C was getting up about, 6 or 7, okay? The problem was, if you look at the studies, a lot of these studies are not hernia related, right? They're just gen surge incisions, colorectal trauma, kind of across the board, right? And we know that diabetes does play a role in some way, shape, or form in wound healing, but how do we know specifically what it does in the world of hernia when we only have specific studies that looked at this specifically, okay? So there's a couple of things out there that kind of give us a little bit more guidance. Like, a couple of studies show that SSI, for the most part, when they're increasing by 30% glucose level, that, over a level of like, 30, when it goes increments of 30% about over 40, when you go above 110, for the most part, then you're starting to talk about an increase in SSI about 30%, okay? So increments of 40 or more gives you a boost about 30% when you go about over 110. And then also, if you look at the data too, it even says that most critically, 24 hours is when you really want that significant control of any episodes of hyperglycemia, because it does impair that initial phase, the proliferation phase of neutrophils. So I think for the most part, in my opinion, the data is kind of weak on this because there's no real strong studies looking specifically at hernia or ab wall reconstruction. But I still tread lightly. When I'm going to do a complex ab wall, I want them to have a hemoglobin A1C about 8 or less, okay? So if they come and they're coming with a hemoglobin of 12, I'm going to send them over to endocrinology. Now, that being said, if I get someone who has a really complex ab wall, their quality of life is poor, they have a hemoglobin A1C of like 12 and they go down to 8.5, I'm going to operate on them, okay? So I think you have to tailor your approach, but use this as guidance, right? There's no really strong cutoff cases here, okay? All right, so we're just gonna touch upon a few more things here, and then I'll hand it over to V here. But for the most part, oh, sorry, this is like a repeat slide. All right, so a couple other things I just want to touch upon. We can spend hours on this, but nutrition status is obviously really important. How do you deliver? Is it a PPN, TPN? Is it enteral feeds? All this comes into play. There's current work being done on this. Like, should we start giving them carbohydrate loading, all this stuff? We kind of went through this with bariatrics years back, maybe about a decade ago. But the data on that is kind of weak, right? So if you have someone who's debilitated and nutritionally, they may need some optimization before surgery, but I probably think the vast majority of ab wall patients are not in that phase. Antibiotic prophylaxis, right? This can also help. This is all part of your pre-optimization. Obviously, 30-60 minutes before an incision. If they have a previous MRSA infection, consider Vanco and maybe cefazolin as well. I think the data on that is actually kind of strong, so I actually tend to do that as well. Preoperative exercise program. So there's definitely some really strong data on there. So if you look at the Abdominal Core Health Initiative, right, and they looked at about just under 3,000 patients, they looked at the studies and they found that makes sense, right? Patients who exercise frequently are associated with lower odds of experiencing a post-op complication. This is not surprising. Makes sense to us, right? They exercise more. They have a higher, they're going to walk more, less likely to get blood clots, PEs, pulmonary issues. They probably are going to have, if they're exercising frequently, probably going to have a lower BMI. It all makes sense, right? So, preoperative program, designated programs, when they've done studies on them, have shown that you certainly have better outcomes. I think as we move to specialization in the field of hernia, where we get very specialized centers of excellence, I think exercise programs are definitely going to become the way of the future, in my opinion. All right, this is a shameless plug, but I'm going to be shameful, and I'm going to put it up there, but this is important. So imaging is extremely important, in my opinion. It can give you a lot of guidance in terms of surgical repairs, mesh, loss of domain, which V's going to talk about in a second here, surgical planning. Radiology is extremely important when you're going to do a complex ab wall reconstruction. So this was a project that we worked on for about 1.5 years, almost 2 years, to put this together. If you're interested in this area, I'm obviously biased, full disclosure, but I think it's a great source. Everything is contained within it. And if you have any interest in this field, I highly recommend reading it. We also, for our friends on this call who are interested in complex ab wall and cover a lot of acute care surgery, there's a prediction models paper that we put out here that summarizes pretty much across the board every radiology prediction model that's currently out there, and that goes from acute care surgery to component separation planning to how do you define where the mesh is, all that other stuff. So just some really solid resources to an area which, again, we could spend a couple hours just talking about this alone. Okay, but this is important because, again, it's going to give you a lot of guidance, right? So when we talk about pre-op planning, if you look at the Tanaka score and you got loss of domain, now you may have to be talking about Botox to give you a better outcome. So it is really useful stuff. And Avi will talk about that in a little bit. Okay. So in conclusion, right? So rehabilitation of ventral hernias is of significant importance. Again, it's a little bit of a changing landscape. I didn't want to dive too much into the data for obesity and robotics and open, but for the most part, as I mentioned before, you got to take this information as guidance and not strict cutoffs, because every patient is always in its own specific situation, okay? It's a changing landscape, but I think for the most part, as long as you're doing what's best for the patient and making sure that they're going to have a good outcome, I don't think you could go wrong. And again, use this information as a guideline. As I mentioned to you, I kind of gave you my opinion, what I currently do. So if you ever need anything, feel free to reach out, and happy to discuss any situation with you a little bit more. So my gallbladder surgery got more Facebook likes than your hernia operation did. I don't think this holds true anymore, in my opinion, but all right. Thanks, everybody.
Yeah, I would argue hernia is getting more attention than the gallbladder nowadays, Sal. So
That's right. That's right.
wonderful. Thank you so much for that. Such a wide, broad topic, and you hit all the high points. So we will take more Q&A. We're going to have Dr. Vahagn Nikolian next. We're going to take more Q&A after he speaks. But if you have any questions along the way for any of the attendees, please put them in the chat. I'll be monitoring. So it's my pleasure to introduce our next speaker in this preoperative section, Dr. Vahagn Nikolian. He's an assistant professor of surgery at Oregon Health and Science University, and he's going to be talking to us about managing loss of domain, pneumoperitoneum, and Botox. That tailors nicely, Sal, with what you were just talking about in regard to radiology. So take it away, Dr. Nikolian.
Hi, everyone, and thank you very much for the opportunity to take part in this very special webinar. A really tough act to follow after Dr. Docimo. but I'll try to do my best. So managing loss of domain. I serve as a consultant for multiple groups. So for today, we're going to have a few objectives. We're going to try to define the concept of loss of domain and the physiologic impact it can have for our patients. We'll review perioperative strategies that we can use to prepare patients for successful hernia repair. And then we'll review data on some of the strategies that we use, like pneumoperitoneum and chemical component separation. So in terms of knowledge checks, we're going to intersperse these throughout our presentations. We're going to try to make it interactive. For anyone that's in the audience that wants to contribute, feel free to connect with us on the Q&A and or the chat, letting us know your sort of baseline knowledge base. Define loss of domain. What are some of the physiologic consequences of loss of domain, and how do we manage patients with loss of domain? We're obviously going to go into the details now. The CT scans here are what present to a lot of advanced abdominal wall centers. These are from my clinic over the last few months. Just really complex scenarios. Loss of domain, I think, really puts us in a position to be creative, but also have to be very careful with what we're trying to do. Really integrating our patients' goals into the conversations and trying our best to make sure that we can have a safe and appropriate outcome, because in the end, many of the procedures that we do are very much dedicated to quality of life. And it's not just about the size of the defect, it's really about the contents. Size only tells you so much. Uh, Sometimes you'll have a patient present with loss of domain, but not necessarily a wide-necked hernia. Hernia sac volume and the ability to reduce that content, it can be very difficult to categorize. And retrospectively, when reviewing this data in databases, can be difficult to identify. Here are a few examples. These were actually both 10-centimeter hernias. The first patient on top is a larger patient. I think they were like over 6'3", and so their interrectus width is 10 centimeters. But anyone that looks at that does advanced abdominal wall surgery would probably call that a nice appetizer type of case. The bowel and solid organs are within the abdominal cavity. The retroperitoneal structures are intact and in an appropriate position. And the ratio of that interrectus width to the total rectus width is it's not that big of a deal. When you compare that to the patient on the lower half of the screen, loss of domain, again, a smaller necked hernia, 10 centimeters, but with a large volume of the intra-abdominal contents and even some of that retroperitoneum being pulled up into either the hernia or to the anterior fascia. So defining loss of domain is not easy. There isn't like one tried and true definition. There's a variety of them. For many people that take care of patients with these large hernias, we kind of joke around and say, you'll know it when you see it. And I think that rings true. In general, when you have a large percentage of the intra-abdominal contents or a very large hernia sac relative to the abdominal a peritoneal cavity, you're going to be looking at a scenario of loss of domain. People will quote between 20 and 50%. The concept of loss of domain has been around for now decades with various and broadly accepted approaches to defining it. There's a lot of local consequences when these patients present with loss of domain. It's not just about a large hernia that's going to be difficult to close. These patients have a lot of physiologic complications and issues that they're dealing with. Many of them have a reduction in their muscle and aponeurotic tissue. There's a significant component of muscular atrophy. Muscles need not only an origin, but a ability to have some counter tension or resistance to function. And when you have loss of domain, you're not going to necessarily have that. And so muscle is not going to work the way it was meant to. There's oftentimes weakening of the diaphragm because of the lower intra-abdominal pressure. I tell my patients when they present like this that they basically have a blowout valve. And they'll come and tell me, I want this hernia fixed because I have difficulty breathing. This hernia makes it difficult to breathe. And it's not because the hernia is large, it's because their diaphragm has gotten weaker. And closing them up is only going to make that more challenging. So preoperative optimization with a focus on pulmonary rehabilitation, I consider it very important in this population. There's oftentimes morphologic changes to the mesentery, secondary to the changes that exist with all of the pulling on that mesentery because of these large hernias. You'll know um, large areas of edema. And I think it makes it even more challenging trying to repair these hernias because the bowel might be edematous. There's a lot of skin and soft tissue complications. So as much as we all love to do robotics, many of these patients don't qualify for robotics or purely robotic or minimally invasive approaches because you have to address the skin and soft tissue envelope for these patients. These are just some pictures of patients who presented with loss of domain. That first patient on top presented with a chronic wound. It ended up being a very low volume fistula. Clearly a patient that's going to need not only a hole closed in the abdominal wall, but a visceral resection. That next patient, a very large hernia, it's difficult to appreciate in the picture, but that panniculus is going all the way down to their knees. And so a resection of that panniculus is going to be necessary to make sure that you have an appropriate soft tissue outcome, which can drive your deep tissue outcomes. And then fistulas, the patient in the center there, or in the bottom there, presenting with multiple loops of intestines that had been incarcerated, strangulated, emergently operated on, and had, almost like a clover leaf pattern of intestine that were penetrating into the skin. So a lot of skin and soft tissue work, a lot of visceral work that has to be taken on whenever taking care of these patients. There's a lot of systemic consequences of loss of domain. We talked a little about the musculoskeletal dysfunction. Beyond just the abdominal wall musculature, these patients will present with low back pain and low back issues because of lumbar lordosis. They'll have a lot of chronic back pain that might be driving them to work towards an operation. But because of that back pain, they can't necessarily prehabilitate appropriately. Many of them will have ventilatory and respiratory dysfunction on CT scans. Hard to appreciate on this CT, but a lot of flattening of the diaphragm, inspiratory and expiratory restriction, and chronic respiratory failure. And these are all the things you need to function well before you go put them under the knife. So again, being proactive about identifying these problems so that you can work with them and other individuals in your care team to assure that the outcome is going to be safe. A lot of chronic GI dysfunction, GU dysfunction, and then psychosocial issues. Many of these patients present, they can be somewhat reclusive. They don't necessarily have an ability to be out and about as much as they would like. They have to make a lot of arrangements to even go out of the house and interact with people. So a lot to navigate whenever you're setting them up for a very big operation. So in preparing for surgery, the physiologic stress of reestablishing domain shouldn't be underestimated. There's a lot of adjunct measures that we can take, and we're going to focus on two of them: progressive preoperative pneumo and botulinum toxin. So what is PPP? PPP is basically the use of pneumoinsufflation to serve as a way to prepare patients for a large-scale ventral hernia repair. Pneumatic tissue expansion is one mechanism that some hypothesize as the way that this works. It increases the length of some of the oblique muscles, the diameter of the abdomen, the volume of the abdominal cavity. Others highlight the importance of this serving as almost like pneumatic lysis of adhesions, insufflating the abdomen, leaving them insufflated for some time, and hopefully loosening up some of the dense adhesions that might be present. And others look at this as an opportunity to induce chronic abdominal hypertension, not necessarily compartment syndrome, and physiologically prepare that patient to breathe against more pressure after the operation. I almost look at this as an opportunity to assess whether or not they have the physiologic reserve to withstand a big operation. So identifying the right patient for PPP is important. Not every patient's going to work well. I look at patients, the morphology of the abdominal wall, and as Dr. Docimo was talking about, CT scan is very important here. Reviewing and understanding, is it a small defect with large contents, which a lot of us would consider a likely good option for PPP? Or is it going to be a wide defect with wide mouth defect with the majority of the viscera outside of the abdominal domain? Technical aspects of PPP, the first thing is, of course, accessing the abdomen safely, placing an intraperitoneal catheter. Whenever I've done this, it's a dialysis catheter with a cuff. I like to place it, make sure that the cuff is in the sub-Q. I usually wait 1 to 5 days to have some epithelialization, and then I will proceed with insufflation. Insufflation is done with sterile air in most cases, at least the published data, although there is some data that's emerged from developing nations where patients are getting discharged with TUMI syringes and just using room air. We aim to have the patient admitted to the hospital. We aim to have them be short of breath when we insufflate them, and then we'll stop the insufflation at that point to serve as much tissue expansion as they'll tolerate. So I think anytime you're thinking about PPP as an adjunct before surgery, it's really important to understand the complication profile. So another knowledge check, what are some of the described complications of PPP? So before we get into that preoperative or PPP pathway, we usually get a CT scan prior to initiation or within a few weeks of initiation. We have to be prepared for systemic anticoagulation. I prefer systemic anticoagulation over IVC filters, though some do advocate for IVC filters as well. And then within 7 to 10 days of initiating PPP, you're going to go ahead and have an interval CT scan to determine whether or not you've had a successful outcome. The complications of PPP, pretty much every patient is going to get subcutaneous emphysema, mediastinal emphysema. These are commonly encountered and rarely require intervention. Patients are, of course, going to feel very full, and their PO intake is likely going to be limited, especially when you're having multiple days of PPP. At some point, you may even end up in a scenario where the patient needs to be intubated. And so being prepared to support them nutritionally is also important. Physiologic collapse, though rare, can be something that can happen, especially when you're really insufflating their belly to high pressure. And so having a understanding of this as a potential complication and having a good care plan in place with your other team members should this happen to assure that patients are safe. The systemic reviews that have been published demonstrate that this is generally considered a safe option. The vast majority of patients are admitted for this, and the outcomes are good. When done right in this appropriate patient population, primary fascial closure rates can be as high as 86%. So this is the summary. It's in the Martinez manuscript in hernia in 2021. If anyone's interested in applying PPP to their patient population, it sort of does a nice summary of the approach and some of the things to look out for. Botulinum toxin or Botox is another great option for patients, and some call it chemical component separation. I'll sort of go through this quickly. This is a great option if you're trying to use it as an adjunct to avoid maybe a component separation or prepare patients with large ventral hernias that are going to need as much domain as possible. Indications for use include a planned abdominal wall reconstruction, but it can also be used in other settings, such as patients with some pain syndromes. Relative contraindications include patients with severe COPD or pre-existing paresis. The COPD, of course, they're oftentimes using their oblique musculature for sort of breathing, and so you don't want to cause any uh, chemical component separation there. The benefits of Botox and the common protocols, increased laxity and the ability to potentially reduce the hernias. The general equipment that we use, injecting about 300 units of Botox in all 3 layers of the abdominal wall in 6 very strategic points. Injecting as lateral as possible so you can denervate the muscles along the entire neurovascular bundle. Studies again have been looked at, meta-analyses have been done recently demonstrating that it's very safe and helps in addressing large hernias. This is what PPP and Botox looks like in my practice. Patients presenting with really complex hernias, patients who require large resections of skin, soft tissue, or skin former grafts, and we're able to really reconstruct them and bring them back to a very normal appearing abdominal wall with limited needs for collaboration with, like rotational muscle flaps from plastics or something like that. So in conclusion, loss of domain is complex and it can result in significant morbidity to patients. I think preoperative adjuncts like PPP and Botox can allow for higher rates of defect closure and good outcomes in patients with relatively lower risk. Thank you very much, and I look forward to our discussion.
Thank you both so much. Really, really fantastic. I feel like I learned so much from these talks as well. So we'll do a Q&A before we move to the next session. So Dr. Nikolian, we did have one question. So again, for any of the attendees, feel free to put your questions in the Q&A or the chat, whichever you're more comfortable with. I'm monitoring both. The question for you, Dr. Nikolian, was what's the duration that you have patients in the hospital for the progressive pneumoperitoneum? Just kind of what does that course look like? And how long do you do the PPP before the operation?
Great question. I'm sorry I didn't address it more
It's a
effectively.
lot of it's a lot of information to present. So
Yeah. Yeah, so a lot of people wonder, usually we're planning for about 7 to 10 days of PPP when doing it. My enthusiasm for PPP is not quite as high as it used to be 3 to 4 years ago. I think just with experience, I've been able to navigate some pretty complex scenarios without necessarily needing some of the adjuncts. And it's somewhat difficult to get approval for my patient population. But when we are doing it, in the most advanced cases, we do at least 7 days in-house, and we're pretty aggressive about it. We're not doing outpatient TUMI syringes and low volume insufflation. We're going pretty aggressive and sometimes even pushing patients to the point of needing to be intubated and paralyzed to maximize the potential for almost a pneumatic tissue expander.
and so the 7 to 10 days that you keep them, with what frequency are you doing the progressive the PPP?
It's about daily,
Okay.
maybe twice a day, once in the morning. If we'll check back on them in the afternoon and try it once more in the night to just insufflate them. And then we leave them insufflated the whole time. I don't know if that's exactly how everyone does it, but that's definitely the way we try to do it, is to leave it insufflated. But again, my enthusiasm for PPP has gone down over the years because I just feel like it does add some significant risk, especially with the potential for blood clots and hemodynamic compromise.
And in addition, they asked in the question, so you re-image right before you operate, right? So you'll do the PPP for the 7 to 10 days pre-op, and then do you re-image, and that's kind of your threshold to determine if the abdominal wall looks pliable enough to operate on.
The re-imaging, I kind of look at it as almost like an academic exercise for me at this point. Really, I'm looking at, I think out of the 3 things that PPP gives me, it's physiologically preparing the patient for that intra-abdominal hypertension that exists after doing a major reconstruction. And so if they're unable to tolerate even a low amount of volume with PPP, I'm very careful about whether or not we should proceed. In patients where we are able to successfully have them tolerate PPP for the week and really increase that intra-abdominal pressure, then I'm more confident that they'll be able to withstand that physiologic stress in the immediate post-op period.
Related to that, what kind of indices or measurements do you use to decide PPP? The attendees asking that it seems as though everything's based on a CT scan, but are there specific calculations, or is it more that it's a little bit nuanced? You were showing the two pictures of, how much in terms of a small defect versus a wide mouth defect. Do you have a cutoff, I guess is the question, or is it more nuanced than that?
Great question. And I'm sorry I'm hogging the discussion. So
The
PPP,
hot topic.
I would say that it's very case by case specific. And again, it's usually looking at that patient that I'm worried about their physiologic reserve. I was doing it more often or more enthusiastic about trying to get this done and pushing patients with that uh, distension of the abdominal wall to see if it was going to result in a lot more compliance. But I think it's the physiological reserve. I don't know if anyone else in the group does PPP and what their thoughts are on whether or not what the mechanism that best suits the patients is.
I kind of I feel like Botox has overtaken it, in my opinion. I feel like the results have been the same, with a lot less, I don't want to say work that goes into it, but a lot less risk for the patient. Because I think having them, having them go through that for 7 to 10 days before surgery is almost like deteriorating to them a little bit. It actually kind of puts them behind the eight ball. The other thing too is and like I said, Botox for the most part, I feel like almost you get very similar outcomes with it, and it's such a lot easier lift for the patient and the physician as well. And the other thing too is it's hard to get these things. I don't know. In Florida, it's like hard. Everything is an argument with the insurance companies here. And B, I don't know if you've had different. I don't know if you have different experiences or how you book them differently. Or you get pre-op. Like for me to submit someone here or admit someone, trying to get that pre-auth is it's just really impossible, to be honest. Because we were like,
Yeah,
what
I
the heck?
think allying with collaborators, integrating in various trials has helped our team increase the ability to give options, especially like Botox to patients. It is very difficult to get approved. I'm in Oregon where incisional hernias are difficult to get approved with 25% rates of denial for Medicare and Medicaid patients. So it's a very unique environment to live and work in with these complex hernias. But yeah, I would agree that Botox, the risk profile seems like it's not as daunting, and the outcomes can be very good.
We'll take one more thing. I'm gonna go to you, Dr. Docimo. So for urine nicotine testing, you made a great point about the nicotine replacement, because I think asking patients to stop completely smoking is not totally realistic. And I appreciate your emphasis on we're talking about open abdominal wall reconstruction. There's a lot of data coming out about especially like inguinal hernia repair and MIS repair. We may not need to follow the same strict algorithm. You mentioned, I believe, and Dr. Nikolian had brought this up, but you can use anabase is like a metabolite within the urine nicotine that you can use, and sometimes that will tell you nicotine patch versus smoking. And I sometimes will use serum carbon monoxide. Have you used that at all? I've had some patients who need to desperately use nicotine, and so I'll use serum carbon monoxide. How often are you facing this issue? Do you feel like you're seeing less issues with smoking overall and nicotine replacement? I mean, you really have to develop that patient surgeon trust. You really emphasize that with all of these things, with the obesity, with the smoking, with the diabetes. They're putting a lot of trust in you.
So as I mentioned before, inguinal hernias, I've gone away from it. Honestly, I don't even ask them anymore. I think it's irrelevant. Um, robotic TARs is kind of, I kind of know where I'm leaning in the future, like what I'm going to do with smoking. I don't want to say one way or the other. Right now, I'll still tell them to quit. For open ab wall, though, still, I'm still a little bit more strict with it. And I think for the most part, these individuals that come in with these really massive ventral hernias, their quality of life is extremely poor, and they're almost on the verge of being desperate. And a lot of times when you have a real conversation with them, they've been to, and I'm being honest, they've been to 2, 3, 4 different surgeons at this point. Sometimes by the time they get to us, and when you just say, "Hey, listen, I need to quit, sir. I need to quit smoking before I do this," they're like, done, And a vast majority of them will actually quit before surgery. A vast majority. Now, if I ask someone to quit and they fail, and we test them like a couple weeks before, uh, then we talk about, that's the patient I talk about the nicotine replacement.
Yeah.
And that's where, yeah. So I think that's where that comes. So that's a really small number of patients. A lot of them are just so motivated to get their lives back that smoking is almost like an irrelevant problem to them. They don't even know when you sit there and explain to them, "Hey, listen, this is what smoking does. If you quit, this is what's going to happen. If you don't quit, this is probably what's going to happen." And they get it pretty quickly. And the majority of them will actually be really motivated to quit. So that small number of people that end up needing nicotine replacement is actually really small, to be honest.
Yeah, that's great. And I think just transparency about all of those things and really that you have their best interest. And these things are more nuanced than I think that was the main point of your talk is there's more nuances to this. It's not so black and white. So thank you all so much. Really wonderful talks. There were a couple additional questions for Dr. Nikolian. He's going to answer them directly in the Q&A. We're going to move on to our next section, which is intraoperative management of clinical decision-making in ventral hernia repair. And it's my pleasure to introduce Dr. Wenwei Tan, who's going to be talking to us about approaches to ventral hernia repair, choosing a technique. Dr. Tan is an assistant professor of surgery at the Medical College of Wisconsin. So thanks for joining us, Dr. Tan.
Great. Well, thanks for having me. Like Dr. Higgins said, I'm going to talk a little bit about choosing a ventral hernia repair technique. I have no disclosures. Our objectives today are to review common techniques in both open and minimally invasive ventral hernia repair, to understand pros and cons for each approach, and to describe indications for each approach and potential methods of repair for common and straightforward clinical scenarios. So before we begin, I do have some caveats. So my caveats are that approaches to and guidelines for hernia repair are constantly evolving. This is in part due to when you look at the literature in our field, there is considerable heterogeneity in study methodology, and with some exceptions, some lack of head-to-head randomized controlled trials comparing different modes of repair for small to medium-sized hernias especially that might be amenable to different approaches. So as a result, there can actually be multiple reasonable approaches to the same clinical scenarios, especially for those smaller to medium-sized midline hernias. Practice patterns may vary by institution, by access to minimally invasive techniques, and also by training and expertise. So everybody put down your pitchforks and just keep that in the back of your mind as we go through this talk. There are some published guidelines that you can reference. I put some of them up here, but these are from the European Hernia Society or the American Hernia Society with the associated links. So to start, we'll talk a little bit about 4 of the most popular ventral hernia repair techniques, especially as it applies to minimally invasive hernia repairs as we are sages. So these 4 are the IPOM Plus, the TAP, the ETAP, and then the TAR. And they're listed on this slide from left to right in what I perceive to be order of increasing difficulty. So we'll start first by talking about the IPOM Plus. So the IPOM Plus is the intraperitoneal onlay mesh repair with closure of the fascial defect. That's where the plus comes in. In the old days, we actually didn't use to close the fascial defect. We would actually just put a piece of barrier coated mesh up there, not close the fascial defect, and fire a double crown row of tacks. So then the distinguishing plus is that closure of the fascial defect. There's a picture of it on the left. You can see we're suturing this mesh in circumferentially. It's barrier coated because it will be facing the viscera. So the pros of this technique are that it's generally technically straightforward, it's easier to master, and it's faster as a result. May be good for patients who have smaller to mid-sized defects. Might also be good for patients who can't tolerate a long time on the table or can't tolerate a long time under general anesthesia or insufflation. So you need to do something that's a little bit more efficient. Might also be good for patients who have had failed repairs with mesh in other positions where you want to go somewhere else. So for example, if they've had like a true overlay, like on top of the anterior rectus fascia or a retrorectus repair and have failed through that, consider doing an IPOM plus. There are some cons, however. One big one is that the mesh will be intraperitoneal, and there's the potential for complications as a result. Things like adhesion formation, obstructions as a result of adhesion formation, mesh erosion being the big ones. There's the need for barrier-coated mesh because it's going to be intraperitoneal, and I'm sure Dr. Blake will also talk about that. And then you do have some limitations in mesh overlap. So this might not be a good approach for people who have very large defects, who have a lot of intra-abdominal adhesions that you'd have to take down to do this, or who have IBD or other conditions where you worry about mesh contacting viscera. Moving on, the next technique we'll talk about is the TAP, or the transabdominal preperitoneal ventral hernia repair. So the thought behind this is you drop a preperitoneal flap, which is kind of the bottom half of this picture on the left. You have that mesh excluded from the peritoneal cavity. That's a picture of macroporous polypropylene mesh there. The pros of this technique is that, again, it's not intraperitoneal, it's excluded. You don't need barrier-coated mesh. According to some studies, this may be less painful than an IPOM and potentially faster than an ETEP, according to some studies. This might be good for patients who have smaller to mid-sized defects and intact peritoneum, patients who have primary umbilical or epigastric hernias. Might not be great for patients who have poor peritoneum or might not be able to accommodate the flap that you need for this technique. These patients might have had prior IPOMs, so that flap is not going to be intact, or who have really, really large defects, which would necessitate making a very large peritoneal flap. Next technique we'll talk about is the ETEP, or the extended totally extraperitoneal repair. So we have a short video that we're going to speed run through. We won't watch the whole thing. The idea behind the ETEP is, very much akin to doing a reef stopa, but this time minimally invasively. So the thought is you kind of parachute in that retrorectus space and then try to stay out of their intraperitoneal cavity. So the first step of this is we're obtaining access to that retrorectus space. You can see we're using an optical access trocar to get into there. And then once we start to develop that plane, it's actually pretty nice and rewarding. All that areolar tissue kind of floats away. And then you have space to develop for placing additional ports. There are multiple ways you can do your port configuration for these. This one is just lateral down that left side. We'll pause here a little bit. This on the top of the screen is rectus fibers on the ipsilateral side. So we're actually on the patient's left side in that retrorectus space. Below us, that white shiny stuff is the posterior sheath that we're incising. So right now we're incising that ipsilateral posterior sheath. You can see that like midline preperitoneal fat. So now we're starting the crossover from the patient's left side into the right side. So here we're in this preperitoneal plane. This patient has a good amount of fat in that preperitoneal space, which is very helpful. And then here we start to reduce some nice fat containing hernias. So this patient had a diastasis as well as like multiple small-ish to medium-ish midline defects. And then we continue, we incise the contralateral posterior sheath. So this on the top of the screen is midline hernia defects. We're going across to the patient's right side and trying to get into the retrorectus space on that right side. So that's contralateral rectus on the top, posterior sheath on the contralateral side, and then some of that preperitoneal fat in the midline. I think when you start doing these, sometimes the anatomy can be a little disorienting. So to review here, this is ipsilateral rectus, contralateral rectus, kind of in that corner. The V shape right there is kind of that midline and hernia defects that we're closing. And then on the bottom, you can actually see both posterior sheaths peeking in a V. All right, so you finish the closure, measure out the space, and then you unroll your mesh. Theoretically, it's a closed space here, so you don't necessarily need to fixate it because the mesh isn't necessarily going to go anywhere in theory. So that's an ETAP in like 2 minutes. The pros of this approach are that the mesh is excluded from the peritoneal cavity again. There's no need for barrier-coated mesh. And this technique is actually pretty easily combinable with other techniques such as a TAR if you should need it, and as well as an inguinal hernia repair. So if you are doing something that, or doing a case where you have like midline hernias as well as an inguinal, it's pretty easy to combine both. As you get down below the arcuate line and that posterior sheath starts to transition in transversalis fascia only, you can actually go one plane below, get into your normal like preperitoneal plane for your inguinal hernia repair. So that's a nice combo to do. This might be good for patients whose intraperitoneal cavity you want to stay out of. For example, if they had a failed IPOM, this might also be a reasonable approach for people who have small to moderately sized midline hernias, as well as an associated diastasis, because then you could repair all of that in your ETAP. The cons include the learning curve, since it's maybe not something that many of us did in residency or have a lot of experience with. Another con is OR time. There are a few studies that have shown that when you compare this to other comparable approaches, such as an IPOM, that the OR time for an ETAP is significantly longer. And the cost savings that you derive from not using barrier-coated mesh get eaten up by the longer OR time. This might not be good for patients who have narrow recti. So if you have a patient with a very small retrorectus space, for example, if you have like a 5-foot tall grandma with a 5 centimeter wide rectus, while I'm not saying that this is impossible, it might be a little bit painful. It might not also be good for patients who have no preperitoneal fat in the midline. For example, if they have like a large upper midline after a Whipple and they've taken down the falciform, while not impossible, an ETAP might also be a little bit more difficult. All right, and then moving on to the last minimally invasive surgical technique that we'll talk about. This is a TAR, so a transversus abdominis release. And what you see here at the top of the screen is the cut edge, the divided transversus abdominis. We're developing that plane below the transversus, and you can see some peritoneum there, so at the bottom of the screen. So the pros here are that with a TAR, you can get myofascial advancement without the need for large lipocutaneous flaps as you would for an anterior component separation. This might be good for patients who have larger defects, for example, greater than 10 centimeters. Might also be good for patients who have chronically retracted or narrow recti, as well as lateral defects, as from a peristomal hernia repair or subcostal incisions. Cons include the learning curve, again, and also OR time, especially when you perform these robotically. Obviously, the patient derives other benefits from having a minimally invasive TAR as opposed to an open one, but it does take time, especially as you are early in your experience. Another potential con is overuse. So I'm sure that many of you saw the New York Times article recently talking about TARs gone wrong. So it's just something to keep in mind when you are vetting these patients, that you want to be judicious in the use of these releases. A TAR might not be good for somebody who has had an anterior component separation because you don't want to destabilize their abdominal wall. So there are a number of techniques available, and also some that we didn't talk about here because we only have 15 minutes. But when these patients come to clinic, I find that sometimes for patients with the mid-size hernias, those are the ones where there might be a lot of possible answers. So some questions to consider when you're working up these patients. Not in any particular order, but these are the things that go through my mind. So question 1 is, how are we going to approach the hernia? Open, laparoscopic, or robotic? Question 2, are we going to use mesh? That's usually yes or no. And then what type of mesh, which Dr. Blake will also answer for us in the next presentation. Question 3, I think, is the question that most trainees will struggle with, and it's, where is that mesh going? So in general, we don't do many onlays or inlays, but viable options are retromuscular, intraperitoneal, and preperitoneal, for example. And I think that's where trainees struggle the most. Question 3 is, do we need a component separation to achieve where our mesh is going? And then bonus question 4 is, if there's a stoma present, what are we doing with it? reversing, resiting, or repairing a peristomal hernia. Sometimes I find it easiest to envision what I want to be the finished product and then think of the technique that we're going to use to get there. So I have a couple kind of soft knowledge checks, or I guess discussion scenarios, and you can use the Zoom chat, I believe, I'm not going to random terror call anybody, but to answer what you might do in this situation. So first scenario is you have a patient with a 3 centimeter umbilical defect that just contains fat. So what would you do, or how would you approach the repair for a patient who's 21 years old and completely healthy? All right, we have 1 vote for IPOM. Okay, we have 1 vote for open repair. And like I said, there are actually multiple correct answers. We have another vote for IPOM. Okay. And chat is disabled.
Okay, then just answer in the Q&A.
Okay.
Perfect.
Open. Okay, excellent. So, like I said earlier, there are a lot of correct answers, and I agree with many of them. And some of it boils down to what you have access to, experience, and what you can do the safest. So, for this, I agree, an open repair is totally reasonable. If you don't enjoy open repairs, and you really want to use the robot, I think an RTAP is also totally reasonable. The one thing I'd say is, somebody who's 21 years old and completely healthy has several decades ahead of them to develop intraperitoneal mesh-related complications. So this might be a patient where you may hesitate to do an IPOM. But again, many correct answers, and the guidance is continually evolving. All right, so why don't we do the next slide? Okay, next scenario. This is a 65-year-old male who's had an open bilateral inguinal hernia repair with mesh. So he's an open bilateral inguinal hernia. He has had some imaging. He has a CT abdomen and pelvis. He has multiple midline, epigastric, and umbilical defects in the setting of a diastasis. And he also has a recurrent right inguinal hernia that he wants you to fix at the same time. How would you approach this patient? Okay, ETEP, ETEP, ETEP plus inguinal. All right. Yeah, I think that's totally reasonable. That's probably what I would lean towards in this setting as well. One of the nice things about the ETEP is that, you can develop that retrorectus space. You can go ahead and fix the diastasis as well as the multiple midline defects. And then you can also continue on. And whether or not you rearrange your ports is totally up to you. But you can also fix the inguinal by docking your ports on the contralateral side in a lateral fashion, if that makes any sense. So yes, I agree with the crowd. That's what I would pick. All right, last one. Oops. This is a 70-year-old female who's had a C-section, remote via fan and steel, and then developed sigmoid volvulus, had to have an XLAP sigmoidectomy and colostomy, which she still has today. So this is her CT abdomen and pelvis. Point out a couple things. So she has a midline defect that's about 11 centimeters there. That's her stoma, which has no peristomal. And then she has another midline defect right there. She tells you, I've had this colostomy. I don't want it anymore. Please reverse it. And colorectal surgery says they'll reverse it for you. They're happy to do so. How would you approach this hernia repair? And would you do it at the same time as the stoma reversal? Open TAR, okay. 1 vote for open TAR. I assume at the same time as the reversal? Open Reustopa, primary repair with PDS, save definitive repair for later. Yeah, so I think this is also a scenario in which there are multiple reasonable answers. So if you want to stage this repair, I think it's totally reasonable, right? The last thing you want to do is do a big abdominal wall reconstruction and then have poop, leak all over it or have a complication with the reversal and then have to go back in. So I think staging it is also reasonable. I think it may also be reasonable to do both at the same time. This one would probably require a TAR, obviously due to the size of the defect and width of the rectuses. But I think it could also safely be performed at the same time as the stoma reversal if they were confident that everything went well. So these are my references, and thank you for the privilege of speaking here today.
Great. Thank you so much, Dr. Tan. Great discussion. We'll move on to our next presenter in this intraoperative section, Dr. Kaela Blake, who's an assistant professor of surgery at the University of Tennessee. And she is going to be talking to us about mesh choices, what to use and when. A great subsequent talk to Dr. Tan's talk on choosing a technique for ventral hernia repair.
Yes,
Dr. Blake.
thank you so much for having me. Yeah, excellent talk, Dr. Tan. That alluded perfectly to my talk. Thank you. Can you guys see this screen okay?
We can't. If you want to try sharing again.
Sorry, 1 second. How about there?
Perfect.
Okay, great. So I'm going to talk about mesh choices and what to use when. I have no disclosures. So part one of this talk is just to understand what your options are. You can't really choose the right mesh if you don't know what your options are. So we're going to go through the categories and characteristics of mesh and specific examples, and then we're going to use what to use. We're going to go into what to use when. So first of all, why are we even using mesh? Real quick, just to start us off. This is the landmark paper that just changed the game in terms of the hernia specialty that started all of us using mesh. So this was published in the New England Journal of Medicine in 2000, and it compared mesh versus primary suture repair for open ventral hernia repairs. And they saw a decreased rate of recurrence from about 43% to 24% at 3 years. So this was the landmark paper that kicked it all off for everybody. And since 2000, a bunch of mesh has come on the field. And this has now become the standard of care for the most durable type of hernia repair. And these other couple of citations on the right lower side are also systematic reviews, meta-analyses that show the same thing, that mesh shows decreased recurrence rates compared to suture repair. So that's why we use mesh. So let's understand our options now. So for mesh, I mean, the main goal here is to have a strong mesh that is durable and it keeps the muscles together. So it has a high tensile strength to withstand our intra-abdominal pressure. So that's the goal here. And so mesh is made in a lot of different ways to achieve that strength. So one aspect that we all consider as hernia specialists is the weight of the mesh. Is this a heavyweight mesh, a medium weight mesh, lightweight mesh? And there's no specific cutoff numbers that are universally accepted, but there's ranges. And so these are generally the ranges that we all kind of consider heavyweight, medium weight, lightweight in terms of gram per meter squared. Pore size is the next thing we consider. Is it microporous or macroporous? And you can tell that microporous mesh, that's going to be a heavier weight mesh. Macroporous, that's going to be typically more of a medium weight mesh than those heavyweight mesh. And when we're choosing these meshes, you also have to consider how well is this going to integrate into the body. Sometimes these macroporous meshes that don't have room for healthy tissue to grow in between the mesh fibers, sometimes that forms a thick scar plate and a capsule, and that mesh never really incorporates. So so a lot of the times we are leaning towards macroporous meshes to prevent like a thick capsule scar plate. But not always. There's times and places for everything. And then the structure of the mesh. The fibers can be made different ways. So woven, knitted, cross-linked, laminated, lots of different ways to make mesh. But this is all the main goal is to make it withstand our abdominal pressure. All right, so let's talk about the categories of mesh. These are the main categories that we have. So whenever we're approaching hernias, like the other speakers have discussed and already alluded to, this is what we're thinking about. So you have permanent synthetic mesh that's going to stay there forever. You have absorbable synthetic mesh. There's different rates that mesh can absorb. They can rapidly absorb or they can be slowly absorbing. Then there's biologic meshes that are made of naturally derived tissues, so human or animal products. And then we have composite meshes. Those are made of multiple materials. So just to go one by one through all four of these categories to show you some specific examples, let's start with the permanent mesh category. So there's three main materials that permanent synthetic mesh is made out of: polypropylene, polyester, PTFE. These are the three ones. So not too difficult to remember. These stay in your body forever. They're synthetic, and polypropylene was the first one to be described. Marlex mesh was the first out of all these to be described in 1958. And since all of these have been developed. So we have the most data on permanent synthetic mesh because they have been around the longest. But so these are examples in each group. I'm sure you guys have probably seen these on your shelves. So yeah, this is the permanent synthetic mesh. Absorbable synthetic. So here's a list of examples of absorbable synthetic: Vicryl, Dexon, BioA, Phasix, Tiger. These are all synthetic. They're made in a lab and they have different rates of absorption. So Vicryl goes away pretty quickly, and Dexon, 60 days, 90 days. Gore, BioA is around 6 months. Phasix is around 18 months. Tiger Matrix is around 3 years. All right, next category, biologic mesh. So these are made of, naturally derived materials. So they can come from pigs, cows, sheep, humans, and these are examples. You've also probably seen these on your shelves. And these mesh, just to give you a historical background. So like I said before, those permanent synthetics, those were the ones first on the market back in the 50s. And what surgeons that was their main thing that they had back then. They didn't have biologics. And so they had to use them in contaminated cases and disaster cases. And they would see long-term complications of permanent mesh. We still see long-term complications of permanent mesh. But that's why some of these absorbable meshes and biologic meshes started coming on the market, because when there are, just frankly dirty cases, sometimes you don't want to reach for a permanent mesh that's going to stay there and cause complications. And there are times and places to use the absorbable and biologic meshes. So that's why these came about. But biologic meshes, they do tend to be more expensive because it's a bigger process to make these. And then our last category between those three is the composites. So these are made of multiple materials. Let's kind of go through some examples of these. So you can have composite mesh that has permanent base material, it has absorbable base material, it has a biologic base material, and then you can add other types of materials to it. So in general, when we talk about using a composite mesh, usually we're talking about a coated mesh in general, not always. I'll go through some other examples, but we're using coated meshes. And what a coated mesh is, when, like Dr. Tan was alluding to when we were talking about IPOM Plus, she's like, I would use a coated mesh. What that is, so that's using a base material. So typically, a lot of times we use something permanent that is going to give you that durability. But if you're putting it intraperitoneal, those are not FDA approved to put in the abdomen. Those tend to cause more adhesions if you're putting an uncoated mesh in the abdomen, where it can be in contact with viscera. So we want a coated mesh that then has a layer of coating on that permanent structure to help prevent adhesions, bowel erosions, fistulas. So whenever you're doing a laparoscopic or minimally invasive surgery or open, and you have to put an intraperitoneal mesh, bridging mesh, whatever you have to do, those need to be coated meshes. So here's examples of those. Peritene DES, Peritex, and you can see the base material that I have listed over there to the left side. Another type of composite mesh are meshes that are also woven. So that's like the Proceed and Ultra Pro and Ovatex. Those have some type of a base material, and then you've woven a different type of material into it. And sometimes you can put those next to viscera, and sometimes you can't. So you just have to look at the package and figure out if those can be put by the viscera or not. But it's those coated ones that we always say that we need next to the viscera. All right, so knowledge check. So use the chat. What are the 3 types of permanent synthetic mesh that we have on our shelves? Is it PTFE, BioA, polyester, polypropylene, Ovatec? What do y'all think are the 3 types? If you want to ask for a permanent synthetic mesh, people would be like, what do you want? And I can't see the chat, so Rana, I'll let you tell me what we got going. Let's see, we have a vote for A, C, and D: PTFE, polyester, polypropylene. We'll keep going. Good, nice, perfect. 100%. Yes, y'all are right. PTFE, polyester, polypropylene. Those are your 3 options for permanent synthetic mesh. All right. So let's keep going. Okay, so now that y'all know the categories of mesh, the examples of mesh, let's talk about when to use what. So let's go back to these 4 categories. Let's first talk about our permanent synthetic mesh. So again, we have the most data on this. This is permanent, it lasts forever. So this is considered the most durable mesh. So when we're thinking of a definitive repair, usually we're all thinking of something permanent. But since it is permanent, again, something to think about, it doesn't go away. So we tend to use these in clean cases and elective cases. You know, these are not your trauma, gunshot wound, stool spillage cases. That's not when we're looking for permanent synthetic meshes. These are also, yeah, just meshes that we're wanting to use that have the most long-term durability. However, there is some data that you can use permanent synthetic mesh in clean contaminated and contaminated cases. This is a randomized controlled trial out of the Cleveland Clinic group that looked at 253 patients that underwent a TAR, so putting mesh in the retromuscular space, and they randomized patients to either getting a medium weight polypropylene mesh or a non-cross-linked porcine dermis stratus. And at 2 years, the recurrence rate was 20% in the biologic group versus 5% in the permanent synthetic, with no main difference in SSI, SSO, or SSOPS. So there is some reasonable, good prospective randomized data showing that medium weight polypropylene macroporous mesh in the retromuscular space is reasonable for contaminated and clean contaminated cases. But whenever you're reading these trials and whenever you're reading literature, like the other speakers have talked about, a lot of our data is just, you have to really look at the demographics, how they're using the mesh, and where they're putting the mesh. So a lot of the data is, there's a lot of heterogeneity in our data. So you cannot apply this trial to something that you're gonna put as an intraperitoneal mesh or a heavyweight microporous mesh. So you would have to specifically use this type of mesh in this location to get the outcomes from this trial. So just something to think about. So that's permanent synthetic. Let's go next to composite. So again, composite, the main way we use composite meshes are usually those barrier coated meshes, the coated meshes. So we do a lot of MIS operations, IPOM pluses, also referred to as IPOM, intraperitoneal underlay mesh. So anytime you're putting stuff, mesh intraperitoneal, which I've already kind of talked about, you're using one of those composite coated meshes. All right, next let's talk about absorbable synthetic. So absorbable synthetic, typically these are gonna go away. So typically you're gonna reach for these when you're not doing the definitive repair. In general, this is when you're getting called in and these are those dirty, contaminated, trauma patients. You're just trying to get off the table, something you're just trying to get the patient out of Dodge. So that's when you're looking for an absorbable synthetic, or if patients just don't want something permanent in their body, that's definitely very reasonable as well. With the caveat of Phasix is one of the newer absorbable synthetic meshes, and this one is often used for definitive repairs. There is some reasonable data on it. It has not, of course, been around as long as the permanent synthetic, so we don't have as much data on it. But we do have some reasonable, meta-analyses, systematic review. This was one of them that was just published earlier this year, showing 21 studies using Phasix with over 18 months of follow-up. So remember, Phasix goes away within 12 to 18 months and leaves just a plate of collagen. So it doesn't leave anything there. And at 18 months, they found overall recurrence rates of around 9% in this meta-analysis, with the SSI of rate of 9% and any complications 31%. So we don't have as much data with Phasix, but early data is showing that this might be reasonable for definitive repairs. So to be determined, more prospective studies are needed on that and more trials. All right, last one, biologics. So same situation here. These were initially brought to the market for those emergent, dirty, contaminated cases, similar as the absorbable synthetics, and same situations if patients don't want permanent mesh. So we as surgeons, we started using these more and more. However, with time, with biologic meshes, they are made, a lot of the biologic meshes have a high content of elastin, and they do tend to stretch out with time. So as we've used this over the last few decades, we've realized that the recurrence rates aren't as great with biologics. But when the times when I'm thinking of using a biologic are those times when I want something thick. So if I got called into a case a month ago or so, and the patient had they had a VRAM on the right and ostomy on the other side. They had a missed bowel injury, there's stool everywhere, and so they were missing their skin and rectus muscle on one side that they'd used for the VRAM. It was after an APR, and the muscle's tight, the skin's tight, so I can't close muscle, I can't close skin, there's stool everywhere. That's when I did reach for a biologic, because these tend to be thicker, and so I just wanted to avoid a fistula. So I sewed that from side to side in a bridged repair or inlay, and then wet to dry on top, dressing changes on top. And so that thicker barrier, in my opinion, it helps keep the moisture in the viscera and helps decrease fistulas. You could potentially use an absorbable synthetic as well, but sometimes those are thinner meshes, and you do have to be careful about too much fluid from the viscera evaporating and getting fistulas. So just something to think about. Biologics also tend to be quite expensive. They tend to be in like 20,000 to 50,000, 60,000 price range, versus absorbable synthetics are typically cheaper, more like 500 to a couple thousands. So that's the difference there. And this is some of the literature that's looking at biologic versus synthetic and the data that we have accumulated over the years. So this was a meta-analysis of only randomized controlled trials looking at the management of ventral hernia repairs, biologic versus synthetic. There's 6 studies, 949 patients, and in general, the hernia recurrence favored the synthetic mesh. You can see the risk ratios over there to the right. So risk of recurrence is a lot lower with synthetic mesh. And for this one, overall complication rates also favored the synthetic mesh. So biologics, we used to think they were great, and we're just seeing more recurrences with them. So we don't really use them for definitive repairs in general. All right, knowledge check. So you're performing an elective robotic hernia repair in a clean setting, and you plan to place intraperitoneal mesh. So doing an IPOM plus or IPOM. What's the best mesh of choice? An uncoated permanent synthetic, a biologic, a rapidly absorbable synthetic that goes away in 6 months, or a coated permanent synthetic mesh?
Looks like coated permanent is what we're getting, Kaela.
Perfect. Let's keep moving because I know we got to go. Good job. That's correct. All right, last question. So you're performing the same thing, elective robotic hernia repair, clean setting. You want to place an IPOM mesh. However, you had a full thickness iatrogenic injury to the bowel, and there was a little bit of stool spillage. You stopped it quickly. You sewed it up. Now what? What are your options? And you can pick one, pick more than one, all of them. So do you want to abort the case and just close the hernia primarily? Abort it and bridge it with an absorbable mesh, a rapidly absorbable mesh? Place a polypropylene mesh in the retromuscular space, or place an intraperitoneal rapidly absorbing mesh, which is kind of the same as a bridge repair.
It looks like we're getting A, abort and close the hernia defect primarily.
Okay, that's very reasonable. Honestly, you could probably argue for all of these.
Yeah, someone else said C, we said A.
Yeah, you probably argue with all of these. If you're you can definitely close it primarily without mesh. That's very safe. If you can't get the fascia together, you could put something absorbable. That's safe. I would use something coated if you're gonna put it intraperitoneal. And then that trial from Cleveland Clinic that I talked about, you could put a macroporous polypropylene medium weight in the retromuscular position. That is also legal, but yeah, so you can kind of argue all of these. All right, that's all I have. Thank you so much. Appreciate it.
Great, wonderful. So much to think about. If you have any questions for the panelists as they go through the talks, please just enter them in the Q&A. They can answer live directly for you. It looks like Dr. Nikolian is answering this question about phasics, and all of you should be able to see the answers that are in there. We are going to move on to our last section, which is the post-operative section. So you've done your preoperative prehab, your Botox or your progressive pneumoperitoneum. You've chosen your approach, you've chosen your mesh. Now, what do you do after the repair? So it's my pleasure to introduce Dr. Ivy Haskins, who's an associate professor of surgery at the University of Nebraska Medical Center, and she is going to be talking to us about ARIS protocols in ventral hernia repair. Dr. Haskins.
All right, guys, we're close to the end, I promise. So good evening to everyone who is on the webinar, and thank you to Dr. Higgins, the resident and fellow task force and the hernia committee for the invitation to be a part of this webinar. I have no disclosures for this presentation. We'll sort of breeze through this, but I wanted to kind of keep the juices flowing a little bit and really gauge everyone's understanding of ERAS protocols as they relate to ventral hernia repair. So quick knowledge check, true or false, there are current standardized ERAS protocols for ventral hernia repair. So A is true and B is false.
False. It looks like people are saying false.
Okay, perfect. So for those of you who said false, you are correct. So with that being said, I do have a few objectives for this talk. The first is I'm going to briefly go over the history of ERAS protocols. We'll talk about some of the components of ERAS protocols, the goal and overall impact of ERAS protocols, and then finally how to develop an ERAS protocol for ventral hernia repair surgeries. So the concept of enhanced recovery after surgery was initially introduced by Henrik Kaela in Copenhagen in 1997, and he actually coined the term fast track surgery. And I think the quote that he sort of his speech when he received the inaugural BJS award really sort of captures his overall goal of ERAS protocols. So he said, "Receiving this award means a great deal to me. I've always thought it is important to look at why patients are in the hospital in the first place, then work backwards from there, step by step, to interrogate the multifactorial issues that can affect their outcomes and recovery. This is what my research has centered around over the last 3 decades, and to this day remains the area I am most interested in and passionate about." So again, he sort of describes ERAS protocols as multifactorial, and we'll go into that in a little bit more detail. But ERAS protocols were first implemented in the field of colon and rectal surgery, and since their inception, ERAS protocols have actually evolved quite significantly. So this includes the establishment of the ERAS Society in 2001, and the expansion and adaptation of ERAS protocols that now cover multiple surgical specialties as well as surgical operations. So ERAS protocols include interventions at all phases of surgical care, and this includes the preoperative phase, the intraoperative phase, and the postoperative phase. And I present these phases as overlapping for 2 reasons. The first being that components of ERAS protocols are often longitudinal and not necessarily isolated to one specific phase of care. And the second is that the components of one phase of care often impact the components of the other phases of care, as well as the overall success of an ERAS protocol. So what are some of the components of the preoperative phase of an ERAS protocol? So this includes preoperative patient counseling, not only to introduce what ERAS is, but also to explain the specific goals of an ERAS protocol as it relates to that patient's specific operation. Nutrition screening and support if it's needed. Optimization of medical comorbidities, which we already heard a little bit about. Avoidance of prolonged fasting, as well as avoidance of routine bowel preparation, and carbohydrate loading. And I just want to highlight that the last 3 really help reduce the risk of a prolonged postoperative ileus. And one of the goals of the ERAS protocol, which we'll talk about, is reducing overall length of stay. Some of the intraoperative components of an ERAS protocol include routine antibiotic prophylaxis, as well as routine VTE prophylaxis. It doesn't really apply to us, but MIS techniques where it's appropriate. I know a lot of this webinar is about open hernias. Standardized anesthesia, which includes appropriate neuromuscular blockade, so you don't want patients to be too deep, as well as avoidance of agents that may increase the risk of postoperative nausea and vomiting. Avoidance of fluid overload, so you want to really judiciously use your IV fluid in the operating room. Limited use of NG tubes, as well as limited use or placement of drains and maintenance of normothermia. And then finally, some of the postoperative components of ERAS protocols. This includes early oral intake, early mobilization. Everything's early. Early removal of urinary catheters, as well as other lines and drains if possible. Again, limited IV fluid resuscitation. You really don't want to overload your patients. Preemptive nausea and emesis control, opioid sparing or multimodal pain control approach. And ensuring that both the patient and the care team understand the goals and expectations for discharge. So there's 3 ultimate goals for any ERAS protocol, and these include an overall decrease length of hospital stay, a decrease in postoperative morbidity, which includes readmission to the hospital, which should ultimately lead to an overall decrease in hospital costs. Okay, so one more knowledge check for my part. Which phase of ERAS is most impactful on patient outcomes? So A, preoperative, B, intraoperative, C, postoperative, or D, you're not sure.
Looks like all of them.
Okay. So, okay, so for those of you who said D, you're correct. So while ERAS protocols include interventions performed at every phase of surgery, there's really no one specific phase or one specific intervention that has been shown to be more impactful. So rather, it's the combination of interventions performed throughout all phases of care that make an ERAS protocol successful. So let's move on to the good and the bad, and I guess maybe the ugly. So while there are several established ERAS protocols that address operations and recovery for many surgical specialties and operations, like we said earlier, there's really no formalized ERAS protocol for hernia surgery. So you can search on the ERAS Society guidelines page, ACS, SAGES, AHS, EHS, any hernia sort of society website, and you will not find a standardized protocol. And that may be a little bit discouraging, but really I think it's an opportunity for us who perform hernia surgery routinely to really hunker down and do some research and investment in an ERAS protocol that we think may be successful for our patients. So I'm just going to share with you our approach at my institution. These slides have a lot of words, so I'm going to try to get through them quickly, just kind of going back to some of the key tenets that we talked about earlier in my talk. So the first is that we selectively perform preoperative optimization, which is tailored to each patient. We also selectively screen for malnutrition and other preoperative evaluations. For example, if we're concerned about the potential for cardiac disease or a new diagnosis of diabetes, we'll screen for that. We perform patient counseling at a specific preoperative appointment. So this includes both verbal and written expectations, which I think is really important for the phases of surgical care. And it is performed by both me as well as my nurse case manager. These expectations are then reinforced at the patient's preoperative anesthesia appointment. So our instructions align with one another. Patients receive a kit of medications in the mail, and that includes scheduled Tylenol, ibuprofen, and gabapentin, which they begin taking 3 days before surgery. They also receive a carbohydrate drink to drink the night before surgery. And if they're not a diabetic, they also drink one on the morning of surgery on their way into the hospital. Patients with a history of MRSA undergo nasal decontamination with mupirocin. We do not routinely perform bowel preparation. Patients are instructed to bathe with a maldetergent soap, and we ask them to avoid shaving the surgical area themselves. Patients also receive additional multimodal pain medications, and a scopolamine is placed in the preoperative area before rolling back to the operating room. So I know Dr. Docimo talked a lot about this. I just wanted to spend one quick minute on preoperative optimization. And this is really to highlight that many of the patients that we're seeing with these complex hernias come to us with multiple and significant comorbidities. And you can have a catch-all for your patients where you ask them to optimize everything. But really what I've found sort of over the course of my career is that if you really ask patients to engage and focus on one or two of their important comorbidities as it relates to their hernia repair, typically they're a little bit more successful in achieving their preoperative goals. So just take that with a grain of salt, how you want to approach it. Next is the intraoperative phase. So we routinely give antibiotic and VTE prophylaxis per the standardized guidelines. All patients undergo general anesthesia with a high dose of Decadron. We try to reduce the use of nitrous oxide or we use total IV anesthesia to help reduce the risk of postoperative nausea and emesis, especially in patients who are coming in with a history of experiencing significant nausea and vomiting postoperatively. All patients undergo a post-induction tap block by our pain team, and if they're not available, we perform this directly during the case. I would just caution on the appropriateness of a post-operative tap block, which I know happens a lot, really for two reasons. The first being that the time of major irritation to the nerves and the abdominal wall is during the hernia repair. So the use of opioids or other agents throughout the case may be a little bit higher with a post-operative tap block. And really the reason that's most important to me, I think, is that while a tap block is technically a sterile procedure, the risk of introduction of infection is not zero. So I don't want any medication, needle, being introduced into the retrorectus space or the preperitoneal space where I just placed a large piece of mesh if it can be avoided at all. The next is maintenance of normothermia. We use an upper body bear hugger to do this. We avoid placement of NG tubes most of the time. So oftentimes patients are getting an OG tube for compression, decompression during the case, and then it's coming out. We place a Foley catheter if we anticipate needing to get near the bladder during our dissection. And our additional adjuncts are outlined in our safety timeout, which we perform with our anesthesia colleagues before the case. And that includes the anticipated duration of the case, anticipated difficulty of the case, our resuscitation goals. And then we really perform a tailored surgical approach with the use of or in conjunction with our anesthesiologist for each patient. And finally is the postoperative phase. So we request that all of our patients are deeply extubated. Some anesthesiologists get worried about that term. So I typically say, can you make sure it's a pretty or peaceful extubation? So you really just don't want the patient coughing. You don't want the patient trying to get up off of the bed, removing the tube themselves, because really that just puts a lot of stress on the hernia that you just fixed. Postoperative labs, including a lactic acid to help direct ongoing fluid resuscitation. We ask our patients to chew gum or drink coffee to help decrease the risk of postoperative ileus, in addition to early diet advancement, avoidance of a PCA if at all possible. We always schedule our patients for a bowel regimen. And then ambulation and the use of an incentive spirometer once they arrive on the surgical floor, as well as PT and OT evaluations if it's needed. And really, I think the most important or best aspect of this phase really is the expected day of discharge as part of our postoperative order set, and the discharge criteria are placed on the patient whiteboard once they arrive on the floor. So there's really quite a bit of literature detailing the impact of ERAS protocols on the field of ventral hernia surgery, and I suspect that there is more to come in this realm. So if we remember earlier in my talk, I discussed the goals of ERAS protocols, and what these studies really have found is that ventral hernia repair ERAS protocols have been found to have an overall impact on hospital length of stay, while reduction in postoperative morbidity and hospital costs really remain to be seen. So where to get started? I just want to end with some suggestions on how you can get started on an ERAS protocol for your institution or in your practice. So the first is to remember that we do not operate in a silo. So there are likely resources or other forms of guidance within your division or your institution. I would also recommend looking into local organizations, for example, your local ACS chapter, as well as national organizations like SAGES. So while there's no standardized ERAS protocol for ventral hernia surgery from any of our national organizations, many of them, including SAGES, do have resources to help get you started. And this includes examples of some other hospital protocols, as well as patient information pamphlets and educational materials on specific aspects of ERAS protocols. The most sort of popular is the opioid sparing discharges. So there's a lot of information out there to help your patients. And that's all I have. So thanks again to Dr. Higgins and the Raft and Hernia committees, and we'll take questions after Dr. Poulose.
Wonderful. Thank you so much. Lots of areas that we can improve upon and continue to learn and grow as hernia surgeons, and ERAS protocols is definitely one of them, but obviously have an impact on post-op care. So thank you so much, Dr. Haskins. And last but not least, we have Dr. Benjamin Poulose from, he's a professor of surgery at The Ohio State University, and he is going to be talking to us today about abdominal core health and physical therapy. This was one of the questions that came up in the Q&A, and I told them that you would be talking about this at the very end, such a relevant topic. So thanks, Dr. Poulose.
Great. Awesome. Thanks for having me. Thanks to SAGES and Rana and the committee for the invitation to speak. So I'll be wrapping up our webinar today on those two issues. These are my disclosures. So the objectives of my talk really is recognizing something really kind of cool, I think, that we all kind of suspect, and that's the interrelatedness of what we do with the anterior abdominal wall, the flanks, the pelvic floor, the diaphragm, and lower back. And importantly, understand when physical therapy can be beneficial to patients after hernia repair or abdominal wall reconstruction. So these are the topics I'm going to cover, and that is, what is abdominal core health and why should we care about it? And then two, the big missed opportunity with physical therapy and recovery after hernia repair. So if you think about how we practice surgery, and I'm appealing to everyone to kind of think a little bit larger than our concept of what we typically do in this fixing holes and hernias, we all have fairly compartmentalized practices. Sometimes we think the anterior abdominal wall is a problem. No, it's the pelvic floor. No, it's the back. Maybe it's a diaphragm. I'd put out there that our clinical and academic divisions really kind of separate us from thinking holistically about the whole functioning of the kind of the torso or the core muscles. I'll also say that our physical therapy colleagues are way ahead of us with this concept in terms of the interrelatedness of these functions of what we call the abdominal core musculature. This is a conceptual model put together by two really talented PT folks that I work with, Steph DeSacy and Ajit Chowdhury here at Ohio State. And the long and short of it is, if you look at the middle box there, core function is really a function of the lower back, the diaphragm, the abdominal wall, and the pelvic floor. And these components work together for us to perform activities of daily living, and we can measure this by self-reported quality of life and those type of things. So if you kind of look at the definitions, and again, this really largely comes from PT, the core musculature is really the circumferential soft tissues of the diaphragm superiorly, the pelvic floor inferiorly, and the abdominal wall and flanks anterolaterally. The most important thing about this is that these are interconnected physiologic components that all function as a unit. And honestly, if you think about this, take a little bit of time, when you talk to patients, it really is kind of all related. Again, you know, I know we're here talking about hernias, focusing on the anterior abdominal wall, but I think that you have to put this in context as it relates to other components of the core musculature. Going back to a little bit of physics, a couple of things for you. Hopefully this doesn't bring back some PTSD for some of us. If you think about Laplace's law in terms of radius, pressure, and tension, and then Pascal's principle, where pressure applied at one part to a fluidic system is applied equally across all parts, it all kind of makes sense. And you prove this every time you do minimally invasive surgery, just by establishing pneumoperitoneum. If you think about it, how are we able to maintain pneumo in this entire area of the abdominal cavity? Well, it goes back to this. It's really kind of a confined space where the pressures are all distributed evenly. This is certainly an example we face on a day-to-day, but if you think about what a patients undergo in terms of the pressures across the abdominal wall and the core musculature, this really becomes very relevant. The field of core health, again, this is not replacing hernia. This is just kind of a bigger way to think about this. It encompasses the stability, function, and quality of life involving this core musculature concept, The maintenance of core health can include exercise, physical therapy, medical therapy. We talk about Botox, compression garments like binders, trusses we often use, alternative medical therapies, acupuncture, yoga. Actually, in my practice, we use a lot of therapeutic yoga, which actually helps out quite a bit. Abdominal wall surgery, hernia repair is really the cornerstone of what we're talking about today and forms a large part of our practices. But this also includes measures to prevent disease, such as hernia prophylaxis. The diseases that we address under the umbrella of core health include intrinsic diseases of the abdominal wall, hernia, diastasis, athletic pubalgia, core muscle injury, benign and malignant tumors, extrinsic diseases of the abdominal wall. This commonly involves prosthetic and intervention-related complications, benign and malignant tumors as well. I'd put out there, hernias are important, but there's more. This is a patient when I moved from Nashville to Columbus, I saw within my first week. He's a 45-year-old farmer. History of colorectal cancer, resected way in the past, comes back, says he's got some itching on his abdominal wall. And here's his stage 4 metastases of his colorectal cancer to his abdominal wall. It's not a hernia, but certainly this is something where we bring to bear the skill set that as hernia surgeons that we have. So is there any evidence for this? And that's this interrelatedness of these components. Well, Dr. Haskins actually provided some really good data regarding this. She looked at 21 patients undergoing abdominal wall reconstruction and found that lo and behold, their back pain scores improved after surgery. So again, a relationship between the anterior abdominal wall and the back. Anders Olsen, a colleague of mine in Sweden, has done probably the most work looking at postpartum diastasis, looked at 60 women prospectively undergoing surgical repair of their postpartum diastasis anteriorly, and found surprisingly that not only did abdominal wall related surveys improve, but they also had improvements in urogenital distress inventory and incontinence questionnaire scores. Again, establishing a link between the anterior abdominal wall and the pelvic floor. A group out of Italy proved that you can actually improve pulmonary function over time after repairing ventral hernias, establishing the link between the anterior abdominal wall and the diaphragm. And I think we're getting more and more information that these are all related components. So I think for those of you who are interested in looking at some of these key questions, we need to move away from fixing holes and actually putting more data behind the more complex improvements that we can afford patients with hernia repair or anterior abdominal wall stabilization. So I think the real questions we need to answer are the following. Can hernia repair improve pelvic floor function, pulmonary function, lower back pain? What happens at the mesh tissue interface long-term for different types of meshes? We actually don't know that. Can long-term mesh use cause adverse immune system modulation or autoimmune issues? I think these are the things that a lot of us, we care about, and certainly our patients care about as well. So moving on now to what I think is one of the biggest missed opportunities in hernia surgery, and that's physical therapy and recovery after hernia repair. So in addition to Dr. DeStacy and Dr. Chowdhury, Dr. Laura Ward is one of our leading clinicians here at Ohio State in PT. I remember when I first moved here, we talked about what we can do in terms of physical therapy and abdominal wall reconstruction. This is what they said, basically. You guys are basically doing a big tendon repair and not doing the appropriate rehab that we know is needed for best function. There's a wealth of information, not only in tendon repair, but in many other aspects of these dynamic areas of our bodies that show that rehab, specifically physical therapy, is needed for optimal function. And we don't use it enough in abdominal wall reconstruction or hernia disease. So really kind of cutting to the chase, preoperative activity level certainly improves outcomes. That data was presented earlier. It's unknown really if PT specifically helps with this preoperatively. Physical therapy is beneficial postoperatively for most patients undergoing hernia repair. It's almost universally covered by insurance. Doing PT that's local to patients really is key. So it needs to happen somewhere near them. And I'll also say you don't just order PT just like someone doesn't order an operation. Physical therapists have an array of expertise, and it needs to be tailored to what happens with the hernia surgery, the operation. So here's a knowledge check. The 4 components of abdominal core musculature include A, B, C, or D. And I'll cut to the chase. The answer is B there. It's the anterior abdominal wall, flanks, lower back, pelvic floor, and diaphragm. One cool thing that we're doing here at Ohio State, we got funded for an NIH trial, randomizing patients to physical therapy after ventral hernia repair. And the cool thing I can report is We just completed our enrollment of just over 100 patients, so hopefully have the results of this in the near future. What I can tell you is that patients do really well with the PT and they love it. And it's really kind of an engaging part of their recovery. So I think regardless of what the trial shows in terms of hard outcomes and whether it improves things, we have shown a really improved amount of engagement in patients in their postoperative recovery. The last thing I wanted to focus on was something that you can give to your patients tomorrow, actually, and that is our ACHQC abdominal core surgery rehab protocol. Our quality collaborative worked over about 7 years to put together a comprehensive rehabilitation protocol for any kind of abdominal surgery, not just hernia repair. If you go to achqc.org, you will find the information. There's an accompanying app as well. And then there are also on the website, the PT protocols, which I'll show you here in a second. Just to give you an example of what I do, when I refer someone for physical therapy after, say, abdominal reconstruction, I have a dot phrase in Epic that I basically put in the comments that says, please schedule for targeted abdominal core PT per the ACHQC protocol. And I even list the website there that they can go to. So what this allows is a physical therapist locally to do the nationally approved protocol for this. And it kind of speaks in their language. And it's something that they can implement locally, even if they have no knowledge of the QC or ab wall reconstruction or anything like that. One kind of important thing is placing these referrals. You have to specify trunk weakness in the referral diagnosis that almost universally allows payment for physical therapy. And most of the time we start PT about 3 to 4 weeks after the operation. So taking you through the QC website, this shows you where it is. This is achqc.org. If you go to the website and you go to the patients link and information, you'll see this, and this is the protocol. There's a patient guide, which is here in a PDF form, but I'll show you that this also is in an app form that patients can download directly and use. There's also a physical therapist guide here. This is the one I mentioned earlier. And so this is the link you can put in your referral to physical therapy. And a physical therapist, once the patient goes and hands just a piece of paper to the PT, they can look this up. Or if it's electronic, they can just click on the link. And there's also an in-hospital guide for your inpatient PT teams to follow as well. And we find also this very useful. So all 3 guides are available for free on the ACHQC website. And you can use this, again, very quickly in your patients without even being a member of the QC. I'll next show you here. This is the accompanying app for patients. So you can go to achqc.org and download this. I have my patients download this in their preoperative information. So basically the patient just goes to the App Store, either Android or Apple, goes to the app. And then what you can do, if you look at the bottom, you can select before a surgery, during surgery, and while they're in the hospital or in the day of the surgery, or after surgery, and just kind of direct them to correspond to the time point of their experience. And it goes through several validated measures of recovery, and also how to do simple things like how to wear the binder, a walking program, self-care for healing, lifting precautions, basically everything you'd want patients to know after having a hernia operation of any sort or abdominal wall reconstruction. This is also, again, linked to the physical therapy component that was designed over several years by multiple experts in PT. There are videos that show patients how to do self-directed exercises. And this helps them maintain the muscle strength needed instead of just in their usual recovery with the usual instructions we give patients. And here's just another example of the videos that are on this app as well. It's really done well, and it's pretty seamless. And it's super easy for patients to use. We find that patients really enjoy using this as part of their recovery. And again, it really kind of handholds patients through the whole recovery process. So I'll stop there. I know it's been kind of a lot of information with all the talks we've had, and also with these components, which I think are really, really important and underutilized, especially as far as the PT is concerned. So happy to answer any questions.
That was fantastic. Look at us being so on time. We have 2 minutes. I mean, I think I really appreciate all the engagement of all the attendees. All your questions in the Q&A have been just fantastic, and so the faculty have been answering accordingly. We do have 2 minutes if there are any other questions moving forward. Dr. Poulose, thanks for showing. That was one of the questions that came up earlier that I said that you would answer, which was the exercises. And I think that the ability of the QC to have that app and for patients to see that and see the videos is very valuable and very helpful. So do you have them do any physical therapy in the hospital, or do you just wait to do the referral outpatient for for like the big abdominal wall reconstruction patients?
Yeah, currently we do have them do PT in the hospital. And what we found is when you instruct your PT colleagues to use the in-hospital PT information, it's an entire different experience. Usually what happens when we order PT for inpatient consults, they're mostly focused on what the patient can do at home and whether or not they need to go to rehab or home, not necessarily what needs to happen in the hospital. They tend to let the OT folks take over that, but I think that's incorrect and a missed opportunity. So that's why it's helpful. So we do
That makes
in-hospital PT now.
That makes sense. What about activity restriction? Thinking of the abdominal wall as a big muscle group with many facets, what do you typically do and recommend in regard to activity restriction?
Yeah, for the first couple of weeks, I mean, I leave it kind of vague and tell people to take it easy and just walk. No one's happy with that instruction. Everyone wants a number. So I tell nothing heavier than 15 pounds. I just no heavy lifting beyond that. I can't get past not giving people a number. And then after 2 weeks, roughly speaking, we have people increase their activity by about 20% of their max every 2 weeks. 25% of their max every 2 weeks.
I think you make a great point. It's all relative to what their baseline functional status is and their activity. And I think just being cognizant of that for sure. Well, it's 8 o'clock on the dot. Thank you all to the amazing speakers. We could talk about hernias for another couple hours for sure. We all love hernias. So thank you. Amazing, amazing talks. We hope you enjoyed this webinar. It was recorded, so you'll be able to go back and see all of the talks again if you want to reference anything, and then feel free to reach out to any of the faculty as well. And if you are not a member of SAGES, please become a member of SAGES. It's such a fantastic organization. So thank you all and have a wonderful night. Take care.